You do it? Yes. So good morning, everyone. I hope you guys are happy to be here with us. I am very, very happy this morning. Thank you for joining us. Thank you for letting us into your clinic at your home. This is the 10th TIA session. Okay. There are two outstanding speakers, of course, world-renowned Dr. Isaac Barzilay, and world traveler, and Dr. Bahrami after him. They're part of the PACE North. Remember, we started this a few years ago. It's been very successful. It brought fresh life to TIA, which is very happy for me as the owner of TIA. I am happy to be the moderator today and supercharge, okay, for today's program and for Spectrum Day Toronto. Guys, I would like to thank my sponsors, and I'll talk a little bit more about them. We have Surgical Room, who has gone through a sort of expansion, amalgamation, with LAR and SAFCO, and there's a new company that is coming in strong in the Canadian market. Maybe Chris can say a few words. I would like to thank Orthodent and Shaw. Okay, so let's start with Chris Goldner from Surgical Room. Chris, thank you for sponsoring the day. You're the primary sponsor. You know what? A few years back, okay, Chris, whenever I would ask the larger dealers to sponsor any courses, they would always say, "We do not do education." Man, has that changed? Okay, that has really changed, because you want to participate in everything we do. But anyways, Chris, tell us what's going on with Surgical Room. And I know you're a one-stop, shop, and you had great prices, great service, but now you guys are growing. Tell us what's going on, Chris.
Perfect. Thanks, Ettore. Yeah, you're completely correct. I wanted to thank everybody for coming to yet another great TIA session. As Ettore said, the big dealers didn't really like CE. We really strongly believed in CE and have been trying to make sure that we support those good programs like TIA, and really excited about today's with Dr. Barzilay and Dr. Bahrami later on. It really fits in nicely with the Surgical Room as your one-stop shop for all your surgical dentistry needs. Anything and everything you need except for the implants, we've got you covered, we've got you taken care of. As Ettore just mentioned, we've been going through some changes on our end. That changes, we now have a sister company that takes care of all your general supply needs called SAFCO Dental Supply Canada. They're a new player in Canada. They've been in the US for some 85 some odd years, but they've moved into Canada, and they've acquired LAR Sales, which some of you may be familiar with. So LAR Sales is slowly becoming SAFCO Dental Supply Canada. They're one of our sister companies. So you probably will be getting, you can't see the flyer on the screen because of the green screen, but their flyers go out to every office in Canada, versus Surgical Room goes out to those offices that we know are surgically minded, surgically focused, like Dr. Barzilay's Prosthodontic Associates gets it every month. And we're just really proud to support strong CE education programs like what Ettore has been building. And we love partnering with people like Ettore, who are visionaries to think towards the future as opposed to the ho-hum saying so. Anyways, I've spoken more than enough. You guys really want to hear Dr. Barzilay. That's what you came here for.
Hey, Chris,
yes, go ahead.
I just want you to remind you that you guys did buy an e-blast, and I gonna send that Safeco 58 pager to everybody either today or tomorrow. Okay,
yeah,
so they will see what it is, and we have an email list of 21,000, so it's okay. Okay, we'll cover.
And if you're at Spectrum Day, come on, drop on by. Surgical Room's there, and the booth beside us will be SAFCO Dental. So come on by, say hello, and meet the folks from both companies.
Okay, thank you, Chris. Now we go to Jerry Ragolia. Jerry, how are you?
Good morning, everyone. Good morning, Ettore. Thank you. For those of you who don't know me, my name is Jerry Ragolia. I've been representing Orthodent for the past 25 years. We are proud to sponsor all of Ettore's courses, whether it's TIA, Dr. Gom, and many others he has. Well, contrary to our name, Orthodent is a state-of-the-art full-service dental laboratory with our head office in Oshawa, Ontario. We do have several labs in the GTA throughout Canada and the US, probably about 25 altogether, I would think. Anyway, I'm sure that we can meet all your expectations, whether it's implants, crown and bridge, orthodontics, aligners, snoring and sleep apnea, and all the latest digital technology. Rest assured, you'll get exceptional quality and the best personalized service from us. For those of you who allow me to email you, I can give you 3 certificates that will tell you 50% off your first cases with us. Enjoy the day. Thank you. Thank you, Tori.
Thanks, Jerry. Thank you very much. Let me introduce you, the speaker. But before I do that, I wanna, because he's gonna be part of the Spectrum Day Toronto. Actually, he's an advisor. We meet regularly every month and we bounce ideas off each other. And then, like a Spectrum Day happens, but he's gonna be there with his team, with the PACE team, and they're doing a potpourri, half a day potpourri on complications on different specialties. So endo, perio, prostho. So it's gonna be an exciting day, guys. If you haven't registered, please register now. Okay, outstanding. We have 62 outstanding speakers, over 100 exhibitors, free admission, free parking, free potpourri. There are 4 tracks for technicians, denturists, hygienists, and of course, clinicians. Okay, there's 1 free Core 1 course, which is sold out. I told you the last time, you guys have first chance. Next year, I'll put 10 Core 1 courses so we can go to 6,000 attendees. I'm telling you right now, guys. And then we have free live entertainment and cocktail. Okay, so this is really, really amazing. Our next TIA for next year, I'm talking, guys, there are plans. I did a survey, 50% wanted Zoom and 50% wanted face-to-face. I'm gonna create a hybrid. We're gonna do a couple of live face-to-face. We're gonna do a couple of evenings and some Zoom. And I explained to you the last time, it is very, very important that we bring the Zoom because it's easier for me to bring in talent from Greece, from Italy, from Saudi Arabia, from Israel, because the costs are not exorbitant. Like for an hour and a half presentation, you cannot bring the talent that we're used to. So, and the same thing, Pace North will continue with new ideas and new topics, which is fantastic. Okay, guys, I'm really excited. Since we last met, guys, if you didn't see the course by Leah El-Matni, you missed something special. Remember, it was sold out, CBCT scan, like how to read. She is terrific. That's finished. We still have some courses that are going on. Crown and Bridge, we have a couple of spots. We have the Perio Live. I think it's sold out. She does, it's really, there's no more space. The veneer course, we have 1 spot. The endo, we have a couple of spots. So if you're interested in any of this course, of course, guys, before I forget, that Dr. Larry Gom, come down to Spectrum Day Toronto, go into his room. He's got 52 for hands-on. It is unbelievable. I keep on asking this guy what the hell he drinks and what he eats to keep on going. He doesn't tell me, but I'll find out and I'll share with everybody, Isaac. Don't worry. Okay. We have also launched the MIT online and on demand, okay, which is the, mentorship infant training with Dr. Leslie David, Scott McLean, and Avi Chalamet. And, we are ready. Education is in full swing. You are muted. Okay, so please turn your video off or I will turn it off, okay, because that distracts the speakers. And yes, you're going to receive a CE certificate. I usually say next week. No, give us a few weeks because of Spectrum Day Toronto. We have already about 1,700 people that are pre-registered. And so it's a really big endeavor to make sure that it will work smooth and will work well. The webinar today will be available on demand after the live session, but you got to ask us. And then we usually give you a 7-day, okay, a 7-day window where you can see it. And then the link will disappear. Okay. You can ask questions for Dr. Isaac Barzilay at the end. His time is very limited because he's going on a train. He's going to do another. He's just a crazy busy man, but he has to go rush to Ottawa and he has another Zoom presentation. But, he's going to answer a few questions, after he's finished. Send them in the chat, which you will see at the bottom of your screen. Okay, so let me introduce Dr. Barzilay. It's very difficult to introduce him because, we're friends. he was one of the first guys that I met, the first clinical guy that I met. I still remember, Isaac, I phoned you from the drama room on my lunch hour. And I said, this guy is at Mount Sinai, he's here. He's gonna say no. You said, come on down, we'll go for lunch. And that's how we started the relationship. You know, so now it's about 26 years, you know, like we've been around for a long time. But let me tell you about Dr. Barzilay. He's been president of most of it, you know, like any influential association, he's been president, APS, ACP, you name it. Currently, you know, graduate from U of T, also graduate from Eastman Dental Center in Rochester in 1986 with a certificate in prosthodontics. He's the head of the division of prosthodontics and restorative at Mount Sinai. He's the head prosthodontic bridge to health, medical and dental. He's an adjunct professor, division of prosthodontics in Rochester. He's a professor at George Brown College. He's an associate in dentistry at the University of Toronto, chief examiner in prosthodontics for the R.C.D.C. And now I think he's the president of the R.C.D.C. I'm not going to say much more than that, but he's also the creator of Build Your Smile Foundation, okay, which is an amazing, charitable organization. And I don't know how he does it, okay, but I'm on the board. I just see how hard he works, you know, to make this happen and organizing it. But, you know, they go to the group it takes to go to Uganda just to do charity work. But now this thing has evolved where they've trained doctors in Uganda. Okay, he's brought people from Uganda to attend George Brown to learn how to make dentures, and then they go back and they do the dentures for these people. It is really a going concern. And if you're interested, you know, in participating, phone PACE and ask for Dr. Barzilay, or you can call me and I will guide you in the right direction. This is called Build Your Smile Foundation. Today, he's going to talk to us about dental futurism. I think I've taken enough of your time, Isaac, so I'm going to turn it over to you. And thank you very much for accepting the invitation, as you always do. It's all yours. Thank you.
Thank you, Ettore. Thank you. So I think we finally figured out the issues here with the PowerPoint. You should be seeing my presentation in front of you. Ettore, I always enjoy your introductions. You know, it's something that my father would love to hear and only my mother would believe. You know, that's really what it's about. The topic that you asked me to talk about was dental futurism. And it's an interesting topic in the sense that you, in fact, Ettore, are one of these dental futurists. You're always thinking ahead, and you're thinking ahead in many different ways. So with that being said, Ettore did mention some things that, you know, that I am associated with. And obviously, I've been very proud of my association with Mount Sinai Hospital, and I'm very proud of the work that we do at the Build Your Smile Dental Foundation. I do a lot of other things as well, and I'm just a busy kind of guy. And when you're a busy kind of guy, okay, you have to realize that there are people who stand behind you and allow you to be busy. And in fact, that's what goes on here. These are the people that stand behind me. These are the people in my practice. We have the dentists at the bottom row, and we have our support staff on the 3 rows above that. And there's a reason that they're on the 3 rows above that, and that's because without them, we can't do what we do. So I always like to give them a shout out to make sure that people understand the value that I place on my staff. And they really are wonderful people. If you've never been to our practice, I welcome you to come and visit. Within our practice, we have a center that's called the Prosthodontic Associates Center for Excellence. It's an education center. And, you know, COVID has changed a lot of what we do and how we do it. So within the center now, we are doing a lot of hands-on programs, and some of the just lecture programs we are doing in virtual. That seems to be what people are looking for these days. We do educate dental students. We do that free of charge. And we provide some very interesting programming. And not that long ago, we got together with Ettore and we said, we've got the same, we're talking to the same people. So why don't we collaborate? And that's where Pace North came in. And with the idea being that some of our programs can be done up north within the envelope or the umbrella of what Ettore does. And so we've been doing this for a little while now, and it seems to work really well. So some of our lectures are done as we are doing today through Pace North. And as Ettore mentioned, we get together regularly just to review what we're doing and how we're doing it and how we can continue to be as fresh as possible. So Ettore spoke briefly about Build Your Smile Dental Foundation. It is a foundation that we started up several years ago. I asked Ettore to be on our board. He graciously agreed. He had no choice, really. He was going to agree whether he liked it or not. And with his help in terms of pushing the message across, what we do is we build smiles for patients internationally as well as locally here at home. And this picture that you see right now shows the smiles that we're able to create. These happen to be on one of our Ugandan trips. And we've come up with ways of making dentures in less than a day, because the trip works on the basis of us going into villages that has no electricity or running water, and we will produce dentures immediately. We don't just produce dentures, we also, obviously, we do extractions and fluoridations and restorative, and we've also been doing some implant work. And nothing is more satisfying than watching a young patient receive an implant and receive a crown for that implant. Uganda's an interesting place. In Uganda, if you're missing a front tooth, you can't get a job and you can't get married. That's, it's an odd thing, but that's how it is. So with that being the case, we have restored many patients with single implants, and we get occasional emails from some of these patients saying how they're happy they are that they received this treatment and they were able to get married and now they have kids, or we get these kind of emails, and it's really quite wonderful. Our next trip to Uganda is at the end of January, and it will be a 2-week trip. So again, if anyone is interested, I'm happy to talk with you directly, or you can get in touch with me through Ettore, and we can see how we can accommodate people's schedules. So that's more or less the way the Uganda Smiles works. Now, what is going to show over here is, in fact, a video of Uganda, but I'm actually going to skip it, just because for time reasons. I just wanted to show this picture here, which shows one of our last teams that was able to go in. COVID made a huge difference to us being able to access international travel. So this was on one of the last trips. We snuck this trip in 2020, right before COVID hit us here in North America. And it was an outstanding trip where we did all the things I talked about. You can see the different countries represented in terms of where all of our volunteers are from. And we work hand in hand with the different people on the ground in Uganda. In fact, at this point, we've opened up a Build Your Smile Dental Foundation office in Uganda, run by Ugandans. It's an NGO, it's a charitable organization where people can come on a regular basis to get work done if necessary. And there are also our contacts and our liaisons with the Ugandan population. We do continue to grow. It's not just an international organization. It is also a local organization, and we treat people from Indigenous groups here in Canada. We treat people from shelters. There's all kinds of people who are involved in this particular in this particular outreach. If you're interested in becoming a Build Your Smile Dental Foundation office, then for that you contact me as well. And we have a program where you can also do volunteer work within your practice and do it under the umbrella of the Build Your Smile organization. So that's a secondary thing. So with that being said, I want to talk about dental futurism. And the idea with dental futurism is to try to look to the future and try to figure out what exactly is going to happen. You know, several years ago, we were all running along at a pretty good pace and everything was fine. And then this disease took over, the pandemic happened, and we had to change a whole bunch of things. And we had to change the way we did things. Nobody expected it. And you really had to look into the future to try to stay ahead of all the regulations and all the silly things that we were being asked to do. And the bottom line is we had to do it because we had no choice. We didn't know what was going on. So dental futurism is a concept. And I think it's a concept that we all need to start looking at. We have to stop being complacent and just looking at what's in front of us. We have to look to the future to see what we think is going to happen 2 years, 5 years, 10 years, 20 years from now. So futurism on its own has a lot of different components to it. If you look on this slide, you see a futuristic chair. This, in fact, does exist. And on one of the Jetson episodes, if any of you remember the Jetsons, the cartoon called the Jetsons, I mean, I watched it when I was a kid, but I'm getting old. So you younger people in the group may or may not know about this, but they also had some interesting futuristic dental type of treatments. So looking forward to the future, I think is something that we need to consider. We have to look through a different set of lenses, and we have to understand that the future is coming up real fast. We cannot forget where we came from, but everything is moving very quickly these days, and it gets very hard to keep track. So there is the past, there is the present, there is the future. There are all kinds of sayings that are used to describe those words. But really, I want to talk about the future and how we're going to get there, I think. Now, I could be making this up completely, and you may or may not believe me. But understand that when we deal with these futuristic ideas, we have to look into what we think is going to happen. So what is futurism? Well, futurism started off as an artistic movement, started in Italy in 1909, and it rejected the traditional forms of the artistic movements and really looked at incorporating dynamism into modern technology. So they were looking into the future in very different ways. It changed the whole shape of the art world. And what do futurists believe? Well, they believe that a simple one-dimensional or single discipline is not satisfactory. Transdisciplinary approaches that look at complex situations have to be taken seriously. They think about systems and how they can evolve. That is crucial. They're motivated by change. And I think that's what we need to be thinking about. Our landscape is changing all the time. We do not sit in one place. Our governance structures are changing all the time. We don't know what's going to happen, from one moment to the next, and we have to be able to respond. Okay. So we look at events, we look at trends of the future, and we anticipate what's going to happen in the future itself. And for many years, we never did this. For those of you who are like me, we're short on hair on top of our head. Our hair, if we have any, is gray. We were taught things in the 80s early 90s. For a long time, we were very happy just doing things as it was. Well, that's just not the case anymore. Things are different. What really makes us focus on that is what effects did COVID have on us? What effects did your inability to provide treatment for your patients have on the patients? And the effects were significant. And I think all of you saw the same things I saw. I saw more caries. I saw cracked teeth all over the place. I saw cracked dentures. I saw more periodontal disease. I saw all kinds of issues. And it took me by surprise. It really took me by surprise. So, what are the effects? So, post-COVID, the changes in effects on the future, really the effects are going to affect technology. Okay, we have more technology now than we did before COVID. And some of this technology is very good, and some you just have to learn how to use. Teledentistry has changed. We're streamlining the intake process, which means patients are filling out more forms online. They're answering questions online. We do some of our consults online. You know, before COVID, we never did that. We just never did that. Now, what about staffing issues? Now, if I say the word staffing issues, I'm sure there's a few smiles out there. You know how difficult it is to find staff at this point. It is difficult to train them. Once you've trained them, they get up and they go somewhere else. It's a very hard environment right now to keep staff. And this has happened since COVID. Okay, but our staff that we do have and that we look for have to be comfortable with new technology. It's not enough to hire somebody to be your assistant, for example, and they don't have a good knowledge of computers or computer systems. That's unacceptable today. We need to have those people comfortable with these new technologies. And it's really difficult. It really is. And I'm sure you're all having the same trouble finding staff to help you with your practices as I am. And I have a lot of staff, but the turnover rate has really changed. And I think it'll settle down. I do. But right now, it's just a very difficult situation. There are new forms of education and the need to have institutions keep up with the technology. Well, you know, when COVID hit, we went immediately to webinars. We did what we called it Pace in Your Pajamas. That's what we called it. And it was a Tuesday morning webinar. We did it every week during the time that we were shut down. And we were forced into that. It wasn't within our plans, but we wanted to continue education. So any of the education that we're teaching today is done differently. You know, Tori talked about webinars and doing things virtually. Well, this is what we have to do. And it's changed. I mean, I've even given a webinar while I've been driving my car. Whoever thought that we would do something like that? So from an education point of view, things are different. The business models are different. So where possible, people are working from home. They don't want to get in their car and drive to an office. They don't want to waste an hour in each direction. You know, it's difficult to drive in Toronto these days. So I'll talk about Toronto because our traffic is crazy. It really is. So people will try to work from home. And on occasion, some of our staff who can in fact work from home will work from home because we've set them up with appropriate technology that it's like they're in the office, but they're actually working from home. And it's just a different model. And we have to be open to it. Obviously, our patients need to be seen face to face. But, you know, so many of our second consults are done virtually now. We don't necessarily have our patients come in. And some of our initial consults are done virtually. So different business model. Let's get used to the concept. We have to understand that all the innovations will support new conditions, but will also cost a substantial amount to the institutions to start them and to maintain them. You have all had increased expenses because of what's happened in the past 2 years. You've all had increased PPE expenses, increased staffing expenses, increased material costs. Everything has gone up. It's hard to manage. It really is hard to manage. We're all in the same boat. The ways of old dentistry will be over with the current generation of dentists, and you must make your practice attractive to buyers with new technologies and systems. So for those of you who are my age and are looking at maybe slowing down or selling your practice and staying on as an associate or retiring or whatever it is that you're planning to do, the way that we've practiced for the past 40 years, that's not the way new people practice. And if someone wants to come and look at your practice or want to buy your practice, they're going to want to see appropriate technology in your practice. So don't stop investing in new technology that will help you sell your practice. I'm often asked when I plan to retire, and my answer is always the same. I will retire when you scrape me off the floor. Now, my staff take real offense because they're picturing scraping me off the floor. Okay, but basically what it means is I don't plan to retire. But again, I have to keep my practice up with technology so that when I do decide not to retire, but to hand over the reins to someone else, they're in a position to do dentistry the way they want to do it. What else about the post-COVID changes? We're doing much, and the work in advance on the phone is really helping us. The staff are trained to deal with patients over the phone, and it's critical. And our auxiliaries are being well trained. There's no reason for me to do every single procedure. We can teach our auxiliaries to do certain procedures. They streamline things for us. I could not do my work without my auxiliary support and without them doing what it is that they are allowed to do. In fact, the RCDSO has now opened up the door for additional education of our auxiliaries so they can do additional procedures under certain circumstances. So when you got back to practice, and this still holds, there's a whole backlog of patients that need care and they need dental access, okay? Our practices have to be sustainable. Many people just shut their practices down and walked away. Well, that's not what we need to be doing. Our workforce needs to be sustainable. This is hard. This right now is really, really difficult. And the identity of dentistry is changing. So let's keep these things in mind. And if I break these things down into their parts, if we start first by looking at the backlog of patient care and dental access, the consequences of the lockdown and the impact and its impact were affected on different patient groups in different ways. The groups that didn't have access really had difficult problems. We missed or diagnosed situations late. Dental disease took over. Oral cancer took over. So again, problems with the backlogs. And we had trouble making sure that we could see our patients. You will still have patients coming in who have not been back to a dentist since COVID started. Please understand that. And it's not going to be pretty what you see. But this is all because of the pandemic. Practice sustainability. The economic environment and concerns regarding the easing of public health restrictions and how this would impact business viability. We recognize that COVID resulted in the closure of dental businesses. Patients had to find treatment elsewhere. This really upset a lot of people, and we have to, let's call it pandemic proof, our practices going into the future. Workforce sustainability. This is a big deal. The long-term implications on the working conditions, particularly the mental health and well-being of us, is at risk. I'm sure you all feel the same way I do. We have a lot more pressure on us these days than we ever had in the past. You find people have much shorter fuses. Our staff have shorter fuses. It's hard to find staff. It's hard to keep staff. Dental education and the workforce sort of stopped for a while. Some of the colleges stopped producing assistants and hygienists, denturists. There's actually a 1-year lull in education because for 1 year they were not accepting new students. All this comes out to affect what we do clinically. So keep in mind that workforce is a big deal. Treat your staff properly and treat them well so that they don't go looking for additional work in other places. Dentistry is risky and it's stressful, and it affects the dental team in many, many different ways. We are finding that our staff members, they're taking more time off, they're taking more sick leave. There's a lot of things that are happening. And we just do the best we can, but understand that that's the condition right now. Dentistry, the identity of dentistry. We've all been in the healthcare system for a very long time. We understand what it is that we're supposed to do, but the importance of oral health and general health and the focus on prevention is coming up more and more and more. Government is looking at these things. They're looking at insisting that we treat patients in certain kinds of ways. But along with that, they're understanding that oral health is a big part of the medical system, and we don't just stand alone. That alone is going to change the way we practice dentistry. There are many policies that are being put across the government, and you're going to see more and more of these affecting us in all kinds of ways. There will be public awareness campaigns, and there will be an enhanced role for us in oral health advocacy. It's not going to be just our private practices where we fix teeth. It's going to go well beyond that. And this is being taught in schools at this point. What do students say about the future? Well, this particular student, Giulia Nich, she was from the University of Foggia. And I'll quote what she said. She said, "I anticipate increasing specialization where there will no longer be just one dentist taking care of all aspects. Rather, he or she will invite the patient to address another colleague who is more specialized on a specific subject. This will happen thanks to better availability and collaboration, as well as through a more structured network." Okay, this is what that particular student felt. Alexander Frenzel from the University of Hamburg said, "As I see it, there's a shift in dentistry already. People are keeping their own teeth longer and they want to keep them, so the focus is turning from therapy to prevention." I think that the future of dentistry will be mostly about prevention and about working in an interdisciplinary way. I guess there are many disciplines in medicine that will increasingly be asked to work together in the future. That's a very healthy way of looking at things. Lena Otto is also from the University of Hamburg. She said most people don't realize that complete health is affected by teeth and oral health. And when your mouth is unhealthy, it can influence other diseases like diabetes. It can impact pregnancy or can even cause miscarriage. I hope there will be more support to help the public maintain a better focus on dental health in relation to the health of the whole body. So dentists and their treatments will no longer be considered as separate from the rest of healthcare. Okay. Simon Schmiel from Hamburg. The future of dentistry is a mixture of prophylaxis and prosthetic dentistry. Both will be important in the future. Caries won't be such a great problem anymore. Clara Plath. I honestly believe that people will keep their natural teeth in their mouths for a very long time. Caries are not such a problem anymore. We should focus more on what happens when people keep their teeth in their mouths for longer as they get older. In that case, periodontitis will become a much bigger problem. Also, people don't want to have prosthesis, so maybe implants and restorations will be requested more often. And she continued, Clara continued. What she said was on another key topic that comes to mind is aesthetics. Because younger people are influenced by the world of social media, they care more about their appearance and will long for white and beautiful teeth more than previous generations. And we've seen this already. We've seen this. So these are students who were just asked to talk about the future. I think they got it right. I think they understand it. Now, where do you go when you give a talk like this? Where do you go to get information? Well, you go to the internet, of course. And I came across the future of dentistry and oral health in an article in the Medical Futurist. I thought this was pretty good. And what they did is they broke down into several different categories. In fact, 9 categories. They broke things down into where they see things happening in the future of dentistry and oral health. And again, 9 categories. The first is artificial intelligence. It's the identification of normal and abnormal structures. It's the diagnosis of disease. It involves prediction of treatment outcomes. And artificial intelligence is already in dental education and dental laboratories. It's going to come more and more into our private practices. This morning, I had somebody send me an email about asking what kind of an implant they were looking at. They sent an X-ray. There are programs online that if you send an X-ray in, the program itself will identify the most likely implant that it's looking at by using artificial intelligence to break down the implant into its different zones, and will give you an estimate of how accurate the computer thinks that implant is in fact what it's suggesting. Really cool stuff. And we can use artificial intelligence in many ways. It's not just in treatments. It will take over in a lot of different parts of the dental practice. And it's something to welcome. It's not something to hide behind. The smart toothbrush. We've seen this thing now for a while. We started off, obviously, with mechanical toothbrushes, many years ago. But then we got into these electric toothbrushes, and they were fine. But now they've become smart, which means they tell you where to brush. They tell you how long to brush. They tell you how much pressure to brush with. They can do it with beeping sounds, or they can do it with your cell phone as well. So they're called smart toothbrushes. What else have we come up with? How about this? This is a robot that places implants. So this concept, the idea of this has been around for a long time. And I saw some early works of this kind of robot where it was really a lot like Star Trek, where there would be a patient in the room and they would have these posts around the patient, which helped triangulate where the patient was. And then you could go in with a handpiece that was pre-programmed, and this could drill implant sites. Where did a lot of this kind of stuff come from? Well, really, it came from missile technology. You know, today missiles can pinpoint exactly what they want to hit with incredible accuracy. And this is just an extension of that. So today, this particular robot that you're looking at exists. And using this robot, you can, in fact, drill a perfect plan based on your CBCT. And this robot will allow you only to drill in one particular spot at one particular angle to one particular depth. And if you try to deviate from that, it won't let you. It won't. And I've tried this robot, and it's incredible. Do we need this? Well, I'm not sure, because we can do something pretty close to this ourselves. But then at the same time, when we're talking about remote locations, or if I want to do surgery on a patient who happens to be in Singapore, I could be able to do it based on this kind of technology. Some of you may have seen this at some of the meetings. It really is cool. This is really cool stuff. Do we have one in the office? No, we don't. Why? Because it's pretty expensive. So we're going to wait for the price to come down a little bit on this. But can we get these kind of results? Yes, we can. It's called guided surgery. And when done properly, we'll get the same results. And we've tested different types of guided surgeries in the office, and they are extremely accurate. So we're pretty cool with what we're doing right now. What else do we have along the futuristic line? Well, we have augmented reality. So these are really just dental simulations. And you've seen this before. You've seen this in digital smile design, how it's possible to take a picture of the patient and give them a new set of teeth, at least in the visual. And you can show this and you can communicate with the patient in terms of what you want to give the patient. And these are great. When this first came out, we were very hesitant about this, because if you simulated something and you couldn't deliver it, you had a problem. But today, this has become much more accurate, and this is something that we do all the time. Virtual reality. I remember virtual reality with these goggles. Originally, it was introduced in dentistry as a solution for anxiety, meaning you could watch movies or you could do different kinds of things while your dentist was looking after your teeth. I don't know, they sort of get in your way a little bit, but the concept is really good. So why not create a different reality for your patient, or even produce educational, call them educational videos in the virtual reality, and have them use this as part of a way to reduce their anxiety. What about for us to teach ourselves how to do new procedures in the virtual reality world? Yes, we have this now. And in some schools, this is how they are teaching restorative, and this is how they are teaching other specialties. It's quite remarkable. Teledentistry. I've already touched on this. Teledentistry is going to become more and more important. As our practices get busier, as our patients just need a consultation before they come in, this becomes a way of communication. A very good way of communicating. Please understand, this doesn't take away from having a patient sit in front of you. Obviously, you cannot do an exam, but you can get 80% of the information that you need by doing this. I'm often asked the question, do I bill for this? And the answer is absolutely yes. You bill for your time. That's what you bill for. And what you're doing here is you're just saving the patient travel time. Okay, that's what you're doing. And in saving the patient's travel time, you can be more efficient. So teledentistry, it's here, it's going to stay. Get used to it. So CAD and 3D printing. You are all very familiar now with computer-assisted design and 3D printing. You all understand how this stuff works. We can design and we can print all kinds of things right now. We can do it in dentistry, we can do it in healthcare, we can do it in medicines, we can do it in different forms of prosthetics, we can do it in organ replacements. This particular concept was highlighted during the COVID crisis to bypass supply chain issues and to meet hospital demands. Do you remember making up your own face masks, finding ways to keep face masks on? We had to do this, and it has become part of what we do. Most dental labs have the ability to print, and they have the ability to produce things in a very digital kind of way. Printing is not expensive. Mind you, there are good printers and there are bad printers. So make sure that if you are into the printing concept, you are using high quality equipment, and you're moving with that particular technology. The concept of using an intraoral scanner to collect information wasn't always done that often. If you look at people who use these scanners, for the longest time, 8 to 10% of dentists were the ones who were actually proposing or suggesting this kind of equipment. That number during the COVID time and now has started to go up. And while we all know that it is possible to use these kinds of scanners to scan our preparations and make our crowns and do things like that, we all know that, but I look at this from a different perspective. I want to try and create a full patient in the computer. So when we see the patient, when they first come in, I have my staff scan the patient. And this produces a model inside the computer. And this model is a baseline. And I can use this model and I can compare future models to it. And I can overlay one model on top of the other so that I can, in fact, look at changes in tooth structure, look at wear of tooth structure, look at movement of tooth structure, look at recession and measure recession over time. This is an incredibly useful tool. So this is something that I highly suggest people get into. This should be part of your original diagnostic series, is getting these scans. Do you charge for scans? Sure you do. It's an impression. It just happens to be digital. Does it take long to do? I'll be honest, I don't know, because I just get my staff to do it. And they love doing it. They absolutely love doing it. And when the patients see these pictures, they think you are just the smartest person in the world, because you're using this new technology. So get used to this concept. The article also talked about intraoral cameras, and this was talking about intraoral cameras not from the perspective of the intraoral scanner, which is extremely detailed, but this is the intraoral camera. You're familiar with the concept where you can show a patient what things look like inside their mouth. And it's a very convenient way of showing people things, especially in areas that you can't really see. Regenerative dentistry. We already have regenerative dentistry when it comes to bone regeneration, soft tissue regeneration. Now we're looking at the idea of using stem cells to stimulate dental or dentin formation. That's totally different. And this will come up more and more as we look to the future. So the way we do fillings is going to change. There's this concept of CRISPR, which means clustered, regularly interspaced, short palindromic repeats. And what is this? It's basically a programmable protein that can edit, eliminate, and turn genes on and off. So in using this is possible new treatment for oral cancer. Okay, it is something that is really new. It's used in other parts of medicine. Only now are we really starting to use more of it in dentistry. You can use this to possibly inhibit plaque formation. You can use it to reduce or prevent dental caries and periodontal disease. There are ethical dilemmas with CRISPR because we are changing genes, we're changing DNA structure, but again, this needs to be worked out. And while the possibilities surrounding CRISPR's medical benefits are seemingly endless, it is not without fault. What this technology boils down to is the rewriting of human DNA. The decision to change the genetic code is not something that can or should be rushed into without careful consideration. And we understand that. But this is here. This is not on the horizon. This is here now. So be aware of it. You know, if you go back in history and you go back to look at what we've done in the past, you will find that in the past, even going back, you're looking at a 14,000-year-old tooth. What did we do for caries 14,000 years ago? Well, we made some tools out of chipped rocks and we ground out holes in some teeth. And what was put into these holes? They figure it was either some form of wax or some form of ground stone or something like that. They don't really know. But our techniques are not that different. We're taking a drill, we're drilling holes in teeth, getting rid of caries or something like that. So this needs to change. This really does need to change. What else needs to change or may change? Let me put it that way. Do-it-yourself dentures. For those of you who remember the Eaton's store, you know, that's where the Eaton Center in Toronto got its name from. Eaton's used to have a catalog, and it went across Canada, and it went to every house in Canada, and you could order anything from the Eaton's catalog, including dentures. In the early days of the catalog, if you bought a do-it-yourself denture kit, they would send you some wax, and you would bite on the wax, you'd send it back, and then 3 weeks later, you'd get a set of dentures in the mail. Now, obviously, was it a good set? Probably not. But this idea of do-it-yourself dentures is not new, but it's out there. Do-it-yourself night guards. We're all familiar with people doing that kind of thing. Okay, there's all kinds of do-it-yourself schemes out there. Is that healthy? Probably not. But it's there, and we're going to see more and more of it. we have to understand it and know how to battle it. So the concept of do-it-yourself dentistry is there. Be aware. Probably now, because of printers and CAD camming, the concept of do-it-yourself dentures this way, using printing, is going to be much more popular. Is it possible to do this? Sure it is. Can you sit there and you stick a camera in your own mouth and take your own scans? Sure you can. Can a patient do it? Sure they can. What kind of result are you going to get? I don't know exactly. However, what sets us apart is we can take these devices and we can fit them properly. And that really is the key. Okay, we still need that touch that we all have as dentists. We still need that. What else is out there in terms of future situations? Overall employment of dentists is projected to grow 17% by the year 2026. This is much faster than the average for all occupations. Demand for dental services will increase as the population ages. Many members of the aging baby boom generation are going to need dental work. And this is what's being published. And I think we understand this. In addition, dentistry is considered number 9 on the list of the 100 best jobs. It's still considered a wonderful job. So let's not forget what position we hold in the public's eye and what services we provide to the public. This is robotics. What is this thing? I don't know if anyone's actually used this thing, but this, in fact, is a robotic office solution for the practice. This is the first functional robot brought into the dental or orthodontic space. This company, it's a robotic software company based in Boston and developed software solutions to run on a robotic platform. And effectively what this robot does is it greets patients. It escorts patients to the operatory. It carries instruments to sterilization. It plays educational videos and music, and it's automatically designed to recharge at the end of the day. Beta testing started about a year ago, and I'm not sure where this is at right now. But I think it's brilliant in many ways. Let's keep track of this. Now what I'm doing is I'm just putting on some, I'm going to show you some pictures of different devices that have been developed recently, which using CAD/CAM technologies and printing technologies, it's been possible to create quickly. This is a flosser. This will floss your teeth, all of them, all at the same time. Now think about it. I don't know anybody who really likes to floss. Certainly I don't like to floss, okay? So what you do here is you scan the mouth, top and bottom, so maxilla and mandible. And in fact, once this particular device is created and the floss is threaded through it, you can bite on it and the floss will line up interproximally and you'll be able to floss your teeth. I think it's quite smart. I haven't tried it, okay? But it comes from a company called Blizzident. And they've had some other devices in the past, some toothbrush devices. They're just looking at ways to floss with a 3D printed mouthpiece. I think it's brilliant. It's someone who's thinking we've talked about thinking outside the box. Well, let's not think outside the box. let's think like there is no box. That's in fact what we have to think about. There is no box, because if you're thinking outside the box, you're still confined in some ways. The thought process is endless. What are you looking at here? You're looking at a paper clip, and that's just for size, because I want you to look at this, this black contraption here. This has a USB connection, and this is in fact a recorder. It is a recorder of audio that you can wear all day long to record everything that you say and everything that is said to you. Why do I bring this up? With the current way that patients are, and with the current legal climates, it's really important for us to have really good notes. It is impossible for us to write down everything that is said and everything that we do. It's impossible. There's too much going on. And you can't leave your notes for the end of the day because you forget stuff. So why not record everything that is said and everything that is done? And at the end of the day, you take that recording, you put it into your computer in a secure place. And if you ever need to refer back to that recording for any reason, be it you need to complete your notes, or be it that you have some legal situation that is coming up, and you need some data from that particular day, you have it. These are not expensive. These are actually very inexpensive. I have tried this kind of technology. I think it's brilliant. In our office, we have written in several different places that we may record from an audio or from a video perspective the work that we do for educational and record-keeping purposes. It's in our medical history form. It's on several different signs around the office. The patients are aware of it. We obviously, we don't video what we're doing in operatories, but we can audio record, again, so we have full information. Because again, with the climate out there, you need full information as often as you can get it. And not only audio, I mean, video is very important. We have video cameras in our surgical suites, but what you're looking at here on the slide is a set of loops with a light, with a video camera, powered by batteries that are supported by the glasses. And this will record what you see through your eyes. It'll record it automatically. This is great for education purposes. It's also great for recording purposes. Do I suggest you do this for everybody? No. But you know what? There are some times that you wish you had done this. Okay, and we all have those situations. I don't want to go into details, but we all have those situations. So you can give this some thought. Where do you buy this stuff? Well, it's where I buy everything. You go to Amazon, they got everything. Where are we going in the future? We're looking at scans of people's faces. We're looking at scans of their teeth. We're looking at radiographic scans, CBCTs, of their bones. We're looking at putting all this information together so that we have a digitized patient in the computer. With this kind of software, you can mimic orthognathic surgery. You can mimic implant surgery. You can see what things will look like if you try to fix things. You can look at the effects on the lips. You can do all kinds of things. But we need to record it somehow. We need to record our planning process. And this is how you do it. Do we have this now? Yes, we do. It's very expensive, but we have it. Will the price go down? Absolutely. And then we can, in fact, embed articulation into these kind of situations. So this, together with articulation and with the patient's face, gives us some incredible potential. What else do we have? Again, this is another one of those great 3D concepts. Let me see if I can get this video to work for you. So you can see here how after making this device, which is like a toothbrush, you can put this device in the patient's mouth and they can just bite into it, wobble around, and they've now brushed their teeth. And the device is made based on the scans of the patient. So this is tailored to the teeth, cleans the teeth perfectly, and brushing time is about 6 seconds. Interesting. From that same company, Blizident. Okay, what about this? So here, you're brushing your teeth, okay? It's hard enough to reach the back teeth. This particular toothbrush incorporates a video camera, so you can actually see where you're brushing. Okay, not bad. You could see it in real time as well. Interesting idea. Now, how about this one? Ever try to brush your teeth when you're out of the house and you don't really have a cup and you don't want to really touch the faucet, but you want to brush your teeth? Look at this gizmo. So this is called a fountain toothbrush. So there you go. That's exactly what it looks like. So you can take water from the tap and you can put it on top of the toothbrush and it sprays up into your mouth and you've now got a fountain as well. I found this online. These are LED lights that are built into orthodontic brackets. The idea being with the LEDs at different frequencies, it helps moving teeth orthodontically quicker. I don't know much about this. I'm a prosthodontist, but some companies are pushing this kind of concept as well. So where does this take us? Well, the future is very bright for much of what we do, but you have to be open to it. The way we practice is going to change. The way we do our dentistry is going to change. The way we talk to our patients is going to change. The way we deal with our staff has changed and it will continue to change. This will all continue non-stop, and we have to be ready for it. We have to take the younger generation of dentists, teach them what we've done in the past, because that's vital. That's how we've maintained ourselves. And you know what? Because it's been so effective, we can't lose that. And in a 4-year program in dental school, you cannot teach everything. So you will take on associates and you will teach them. They will learn. They will probably buy practices at some point, and we will continue to evolve. We've not finished evolving. We will continue to evolve. And it's really with that that I want to thank you for your attention. It's fun talking about these things. It's fun researching these things. I hope you enjoyed, and we probably have a bunch of questions. So I'm going to stop sharing my screen at this point.
Yeah,
And-
Isaac, there is
go.
a comment from Dr. Akshay Thakur. He said, "This is my first time attending. Thanks for bringing such a wonderful speaker." So there, you made a new fan. Okay, like you don't even know. But I tell you something, there was one question that came in from Dr. Gum. Okay, and
Yes.
it's interesting because yesterday I met with one guy that I used to teach, Isaac, at York University. and he said, he's retired now, doing nothing. And he said to me, he goes, you know what? All these companies are buying the smaller dentists, and I just miss. To me, it was like going to the barbershop. I want to go to the same barbershop, and I miss it. So I'll read what Larry said. Okay, Dr. Gum said, he goes, advancing dentistry into the future with modern technologies is a wonderful concept. I fear the loss of the old personal touch. Even as we speak, there is already very little one-on-one doctor-patient relationships. How do we accomplish an even balance between the old and the new? Thank you, Dr. Gum.
Well, Larry always has a good way of looking at things. And it's a very matter-of-fact way. We all know exactly what he's talking about. Today, things are getting mechanized to the point where we are losing touch with our patients in some ways. And it's only through our own efforts that we have to slow that particular thing down. I feel in my practice, I have not lost touch with my patients because I take the time to talk to them. And I think that's really the issue. We're very caught up in time-oriented things. And with some of the larger corporations buying the smaller practices, the way larger corporations make money, there's different ways that they produce income for their shareholders. But I don't think that any of the corporations are against us spending time with our patients as long as we produce as we need to produce. It's not what it was like when Dr. Gom started practice. It's not what it was like when I started practice. Now, I think Larry may be listening to this because I see him on the list, but Larry started practice before I started practice. And even from that time, things changed. So I'm very aware of that. And I just take the time to talk to our patients because they need to be talked to. If you don't talk to them, our patients go to see the dentist, and in these corporate offices, they'll see a different dentist every time they show up. And that's a problem. That's actually a very big problem because ultimately, I do see some of these patients and they don't want to go back to those other offices because they feel like they've lost the touch. The name of the author, or there's a book out there that talks about how the Four Seasons hotel chain was developed and what are their philosophies. The book is written by Izchak, who is the original developer of Four Seasons. And we have to create practices that use the four-season concept of how to treat our customers, our patients. And I think that's what we need to get into, Ettore. I don't know of any other way of looking at it. I really don't. But that great comment, Larry, great comment. Let's see what else we have. I'm going to go to the chat list here.
Okay. There's another question from Dr. Neil Silver.
Sure.
He says, what procedures as the R.C.D.S.O. opened up to perform? Are there any courses assistants can take to allow them to do more?
There are. I know what they did is they opened up, and again, I'm not an expert in this, but they opened up for hygienists to officially take certain orthodontic courses so they could be involved in more of the ortho procedures. And on paper, at least, they opened up the concept for assistants to take certain courses that would allow them to do prosthetic and certain restorative procedures. That's my understanding. But I believe that the limiting factor was these courses, at least as of a year ago, had to be given in a university or school type setting, which limits the ability to really get out there to the masses. So I don't know the details about that, but I know there is something on the books. I wish, Neil, I could give you more information. I don't have it at hand. If you like, email me and I'll try to get you some information.
Okay, another comment, Isaac, from Bobby Bag. Great presentation, Dr. Barzilay. New innovative concepts. you have presented. Thank you very much. Isaac, I have a comment, okay? Like, first of all, I would like to thank you really for finding the time. I know how busy you are. Or there's Parvaneh now coming in and she's saying UT as a course, okay?
Okay.
So, but I gotta tell you, Isaac, and it's very informative, thought-provoking. But tell me, okay, I was in your office when we had the last foundation meeting, and I see that there's construction going on. And I also hear that there's, recession, a resignation, bada bam, bada boom. So why is your time set? What is your mindset that you're expanding, okay, when everybody else is trying to shrink, okay? So, and I mean, the numbers are there, like you're painting a good things, there are gonna be more jobs, more dentists, so on and so forth, okay? So tell me, why are you expanding? At the same time, I wanna tell you something, okay? Because now there's a movement that I see, Isaac, where technicians are going to work in the dentist office. But you did that about 20 years ago, 15, 20 years ago, you had okay? So you're always ahead of your time. Why are you expanding? That's a bottom question. Why space? Which is a beautiful office, and it's the one that we choose to do the GUM live. I thank you in front of everybody because he allows us to use to Pace Clinic, which is beautiful. But he's expanding it. Why, Isaac? 2 more minutes that you have, okay? I'm not gonna let you go.
Oh, Ettore, it's interesting. Even my staff looked at me and go, "You're doing what? You're going to expand what?" And my late father, before I started practicing at Young and Eglinton, he said to me, I was down at Bain Gerard, and he said to me, "Listen, there's this place at Young and Eglinton." I go, "Dad, there's so many prosthodontists in that area. I don't know. I don't think it's a good idea to go there. There's just too many of them." And my father said to me, "Are you crazy? If it's good for them, it's good for you. You come and you look at this and you see if it's a good idea. Don't think that that's a reason not to do something." And whenever I've expanded my practice, and I started off with 1,200 square feet at Young and Eglinton, and then it grew to 1,500, and then to 2,200, and now and at this point we're up at around 8,500, and we're going to grow another 1,000. So we'll be up at 9,500 square feet. And so why do I do that? Why do I keep on growing? Because I think there's real potential. I think there's the need, and I think there's the ability, if you find the right people to work together and produce wonderful dentistry. But to do that, you need the facility. You really do need the facility. And I know that there are offices out there that are running 10 chairs, 15 chairs, and a lot of it is hygiene based and things like that. And these are probably people who are visionaries as well. I believe there's room for expansion. I believe that we should be expanding. In my particular case, Tori, I know I showed you the space, but in my particular space, when you're in a building, in an office building, and space becomes available right next to you, you have to ask the question, should I take it? Because that doesn't happen very often. It really doesn't. And I had that opportunity. I could have taken more than 1,000 square feet, but I decided not to. I believe that in my kind of practice, which is a specialty practice, it's not just prosthodontic, it's also perio, it's also endo, it's also oral surgery. I believe we have the ability to incorporate additional specialists. And I like the concept of having other specialists join us where they don't have to deal with the everyday mundane parts about the practice. They don't have to deal with billing. They don't have to deal with staff. They don't have to deal with rent. They don't have to deal with anything. You come in, you work, you leave. And we've had we've had dentists approach us who say, I like what I do, but I hate the administrative part of it. And they want to join a practice similar to ours. So to do that, I also need space. So I believe that we're constantly in a growth situation. I believe the moment that you decide you're going to stop growing, or you're going to just sort of go level, you're moving backwards. I truly believe that. You should never stop thinking of what's going to happen in the future. And it just plays into what we talked about today. You never, ever, ever stop. And that's my best way of saying it, Tori.
Thank you, Isaac. I just wanna read another couple of comments, and one, Parvaneh, I think she's warming up because she's the next speaker. Thanks, IB, as always, very informative. Okay, and the excellent presentation. And then of course you're a visionary and make the vision happen. And then of course Bobby Bag chimes in. I agree with you totally, but I'll finish it off with the gum comment, okay, which is really priceless. It was excellent presentation, Dr. Barzilay. See you in the future. Larry Gum.
I love it. I love it.
Anyways, Isaac, thank
Yes,
you very
sir.
much. We still love you. Hey guys, one more comment. Because we meet regularly for breakfast, and a lot of the time we talk and we joke, and he was asking me, I don't know, four or five breakfasts ago, what kind of walking cane are we going to use when we're 80 and still working? I said, Isaac, are we going to still working? He goes, oh yeah, we are. So he's so sure of the future. Anyways, Isaac, it's a pleasure. I'll let you go. Okay, thank you. We love you. And we'll talk to you soon. We'll see you next week. Anyways, at
Absolutely.
Spectrum Day, and of course, good luck in Ottawa today.
Absolutely.
Thank you, Isaac.
Absolutely. Thank you, everyone, and we will see you all very soon. Take
Thank
good
you.
care. See you.
Bye-bye.
Bye-bye.
Well, that was fun, guys. I must admit, I really enjoyed it. It was different. We're going to go now to the other sponsor, and the other sponsor, before I introduce the Dr. Parvaneh Bahrami, is Shauna. Shauna comes to us not from Shaw Lab Group. My computer is misbehaving today, and that's a company that I always want to do work more with, and I think we will as we progress. We're gonna do more and more. But they're they're a mover and a shaker. In fact, that's where our next course with the Perio course is gonna be held at the Shaw. And I was hesitant before, Sean. I don't know if I mentioned it before, because we had no fridges, and we have pig jaws. And I said to Ali, Ali, I'm sorry, I know you're offering this thing, but I can't. It's a beautiful space. And so he phoned me 2 days later, goes, okay, I bought the fridge there. You're going to name it after you. But so what are you going to do now? Well, we're there. Anyway, Shauna, good morning. Let us know what's going on.
Yes, good morning, Ettore, and thank you for the Shaw introduction. Welcome everyone to this great webinar. Speaking of the future, I really feel that Shaw Lab Group is the future of dentistry. We have made the move to a very large facility, state of the art. Even though dentists are purchasing and scanners and really getting into their own digital world, as a lab, we are here to support our dentists, to support in the partnership of moving forward. My name's Shauna, and I'm one of the territory managers for Shaw Lab. We are a full service laboratory that has been working with dentists for over 77 years. Our 4 locations are GTA, Kingston, London, and Ottawa. We're very active in continuing education. So if anyone wants to hold a course, like Ettore was saying, in GTA, by all means, contact us. We have a great facility. The one that's coming up that we are personally hosting is our very own orthodontist, Sergio Manet, is doing a cross Ontario tour. So if you have your phone out and the camera is on, you can scan the QR code, and then you can register for one of those locations that's convenient for you. As well, we do offer private tours of our GTA location. We do offer private tours for all the Shaw labs across Ontario. However, this is the hub. So if you scanned here, contacted me directly, I could arrange those for you. For the remainder of 2022, if you choose to send a scan to Shaw Lab Group, we will reduce your lab fee of $20. And I want to thank everyone for attending today. This is my information. I will put it in the chat if you'd like to be in touch with us. That would be wonderful. Enjoy the rest of your webinar.
Thank you. And thank you for sponsoring, because, without you guys, I could not okay? I could not do it, okay? We could not do it. So thank you to Shaw, thank you to also to Procter and Gamble, who still wants us to give, like, I mean, talking about, Isaac was talking about, artificial intelligence. Their toothbrush, the iOS, is artificial intelligence, and it's unbelievable that you put a sensor in your mouth, okay? And then you can see what spots you've missed when you brush, okay? So, like she's giving us either a toothbrush or a flosser, the new water flosser, Robin Shields. I love her. She is, like, she's so generous, like, and she helps, she loves her job. So I'm gonna ask you, okay, Shauna, to pick a number from 1 to 76. That's the people that are in today.
73.
Okay. Okay. Dr. Wan Lee Wong. Okay, so I'm gonna give your name to Procter and Gamble, and they'll bring the gift to your office. Okay, that's what it is. And again, I remind you guys that, like, there's other dentists that take the remote because they come in from Calgary and Vancouver. You can access that too, but you got to phone the office and ask us for the remote. Okay, for the and then we'll give it to you with the 1 week timeline. Okay. Again, I remind you, please. Don't start phoning this afternoon for the certificate. It's going to take a little longer because of Spectrum Day Toronto. Thanks, Shauna.
Thank you, Tori.
Okay, we'll see you. Are you coming to Spectrum Day or are you busy in Ottawa?
I think I have some things in Ottawa.
You guys are going to be all over Spectrum Day because you are in the GOM room, in the Crown and Bridge room. Yes. You guys are all over. Anyways, thank you very much. Okay, right, now let's go to our next speaker, who is my periodontist of choice, because, like I always talk about, I have no cavity. Well, I had a deep pocket that she had to fix, and she did a great job, like a no bruising, nothing, in a couple of days. You can explain it to them, Dr. Bahrami, what you did, but I love it. And she also the one that does the, she does our course, the Perio course. I think we're up to either 16 or 17. I know you don't want any more, but I'm gonna try to squeeze them in. You know me, okay? Because there's some potentials. So, but let me introduce you first. And guys, exciting news, because like just like Larry, Dr. Gom as a live, we've been talking with Dr. Bahrami, and we're gonna try to do like a Perio course with live patients too in 2023. Stay tuned. I'll keep you in crown lengthening and then a live. So let me give you very quickly a little bit of background on Dr. Bahrami. She graduated in dentistry in Iran in 1992. She completed the qualified program at the Faculty of Dentistry in Toronto with honors in 2004. She continued her education at the graduate level with specialty training in perio and implant at the Faculty of Toronto, and she got her degree in 2012. So she has now more than a decade of experience in general dentistry, just like Dr. Gom, before they went into specialist. I think these kind of guys are really special, okay? Before becoming a specialist, has been an invaluable asset in the understanding of treating patients and working with referring dentists. She's a board-certified perio in Canada, a fellow of the RCDC. She's also a board-certified American Board of Periodontology and is a diplomat of the American Academy of Periodontology. She has the diplomat status with ICOI, and she's a clinical instructor in perio in the perio department at the Faculty of University of Toronto. But best of all, she is just a wonderful human being, always willing to share her knowledge with all her colleagues. I gotta turn it over to you. I know you also have a commitment. It's all yours, Pari. Get it done.
Okay, thank you so much for your introduction, your kind introduction, Tori. It's always a pleasure to work with you. So I'm gonna start right away. Let's share my screen.
Okay, we see it, Pari. We're okay.
You're okay?
But it's not full screen yet.
It's, oh, okay.
I can see your 207 slides.
I think because I have another screen, I detached it. Let me see. Go back. How about now?
Okay, perfect. Okay, thank you.
Thank you so much, Ettore. It's you guys are amazing. As Dr. Barzilay, I wrote, there is a visionary that makes things happen. You also make things happen, these sessions, either virtual or in person. I know there's a lot of behind the scene going on. And I appreciate it. We know how much effort is behind this. This talk that I'm having today is actually a glance to introduction into the soft tissue grafting course that I do. It's a full day, so you can imagine just in an hour, which now has been reduced, an hour and a half, that now 10 minutes of it is gone. And unfortunately, I have to leave today sharp at the finish time because I have another presentation. You can appreciate that it's just going to be, I try to formulate it in a way that you can at least take some messages with you, some practical messages to your practices, and helps you understanding a very common condition that we all see during our clinical day. So anyway, again, thank you for being here with us today. As you see, the title is Graft or Not to Graft. Well, basically, it's $1 million question. We see recessions in our practice almost in every patient's mouth, and almost, I said, because we're going to get to the stat later. That's why understanding the risk factors, how to address them, knowing the surgical techniques even. Sometimes when the attendees come to the surgery course, the surgical part and the hands-on, some of them, they may not even do it later on in their practice. They may not get to the surgical part, but having a good understanding of what we're doing or what the other practitioner does, what your patient expects, it helps you in a timely referral, in giving the information to the patient, and evaluation of the situation. Because when we see this situation, we're thinking like, what do I do? Should I even do anything? Should I just monitor the recession? When is the time that I have to refer this patient? Am I doing the right thing, just monitoring, or am I being aggressive, referring the patient to the specialist for the grafting? These are all the questions going on in our head because we are all looking out for our patients and we want to, maximize their time, their cost goes down. Like it's not fun to send a patient for something that is not in a timely manner. The patient has to spend on a specialist fee, come in, different office, different staff, a different experience. But it definitely helps when it's a timely referral. So when I was preparing this talk, this came to my mind and I was thinking snails are very slow, but every time I've seen a snail just beside me, I just looked and they are there. It used to be a lot of them in north of Iran, and I noticed them when they were just beside me. I never saw them coming, although they are very slow. I think I made that analogy with the recession. I was thinking, has any of you seen recession in progress? We monitor a lot of recessions in our practice. We bring the patient back every 6 months and monitor. But then one day, all of a sudden, the hygienist calls us in the room and say, you know what, you may want to have a look at the 4-4 buckle, and they're giving us the heads up that we're not going to see something that we like. So I think all these concern and question comes up from the concern that we don't want to see we have lost that windows of opportunity to refer our patient or to interfere. So basically, and believe me, the reason I'm sharing this with you, that I'm sharing my thought process, how I look at the recession, how I evaluate, and then you can take away and you can feel the pain with me that sometimes there is no definitive answer, but there are some answers in the literature. There are some clinical signs and symptoms that we can go with. So we're going to get some definitive answers and we're going to get some non-definitive answers. As always, it goes back to our clinical judgment. So recessions are quite common. So are the clinical conditions that are associated with them, such as sensitivity, aesthetic concerns, and so on. So we know that the recession increases gradually with age. And basically, 90% of the population over 65, at least they have one recession site in their mouth. Half of us that we have attended this webinar, half of us, at least we have one site in our mouth with at least 3 millimeters of recession, which is significant. So that's why when you go to practice, every patient you examine, you're going to see some recession. And that's why we're talking about it, because it's very common. We all know what recession is. And if we want to go and, define the recession, some may get offended and say, I know what the recession is. Recession is the migration of the gingival margin apically. Then we have the recession. But sometimes, in a very rare occasions, we forget the second requirement for the recession, which is root exposure. So we have a condition, it's called relative recession, that when you see the tooth, it may look like that there's the gingival margin has moved apically, but it might be located more apically when you compare it to the adjacent teeth. Pick up the Explorer and go over the tooth, the crown. Sometimes when I see a recession and I do that, I don't find any exposed cementum. It's all enamel. So either it's because of the passive eruption of other teeth or because this is just the way the gingival margin is positioned. Try to locate the CJ. Sometimes I also get the help from the X-ray to locate the CJ. So basically what I'm trying to say is when we do the grafting, we need to have an exposed cementum to do the soft tissue grafting. If I'm dealing with enamel, grafting does not work. So keep an eye out for such conditions and you may see it. I've seen a few, but once in a while I see these situations, especially in young adults. So let's review some basic anatomy. We know that the keratonized gingiva includes the free gingival margin, which is not attached. And then we have attached gingiva, and then we hit the mucogingival junction, which beyond that we have the oral mucosa. So basically, the width of the attached gingiva is the width of your keratonized tissue minus your probing depth. So that's why all attached gingiva is keratonized, but not all the keratonized gingiva is attached. This is significant because when you get to the evaluation of a recession around a tooth, imagine even this exact situation be in front of you clinically. If you probe mid-buccal and you have a 1 millimeter probing depth, it makes a difference rather than if you go 3 millimeter probing depth. So always probe around the teeth with the recession to see what, like how much attached gingiva you're dealing with and measure it. For basically when I assess the recession site, we assess the components of the mucogingival complex, which includes recession, pocket depth, attached gingiva, keratinized tissue, frenum pool, and gingival phenotype, which used to be called biotype. Now, after the 2017 World Workshop, that they changed the classification, they also changed this wording. So the gingival phenotype is the same as before gingival biotype. Why the gingival phenotype is important? First of all, you all have experience in your in patients, and you've observed this. So I'm going to go very quickly. We have either a thin scalloped phenotype, which the gingiva is translucent, is delicate, is more associated with triangular crowns, and interproximal contacts are located more coronally, close to the incisal edge. And there is a narrow zone of keratinized tissue. If we deal with the thick, flat phenotype, they basically have a thick fibrotic gingiva, mostly associated with the square-shaped teeth, and interproximal contacts, they're more apically located. And we have a wide zone of keratinized tissue. Sometimes we look at the patients and I'm trying to tell my assistant to record that this is a thin phenotype or thick. I look at it and I feel like it doesn't fall in any of this category, because we have a third category, which we see a thick scalloped phenotype gingiva, looks thick and fibrotic, but you see that it's associated with a kind of more, not very square shape crowns, in more triangular and slender teeth. There is a thick band of keratinized tissue, but it's narrow. It's not that wide. So, and you have a thin tissue. So when you move more apically, if you see the situation in between, excuse me, that falls under the third category, which is thick scallop phenotype, or I put it as intermediate. So the white of the keratinized gingiva varies in different parts of the mouth. In maxilla, the buccal gingiva is generally widest in the anterior teeth, and more specifically on the area of the incisors, and gets most narrow adjacent to the premolars. In mandible, it is narrowed in canine and first premolar area, as you follow on this diagram. And this basically coincides with what we see clinically. You see most of the recession on the buccal of the canines and premolars, either in maxilla or mandible, or you find most of the minimal attached gingiva or minimal keratinized tissue there. So in the lingual, in the mandible, is the other way around. The gingiva and the lingual aspects is particularly narrow in the area of the incisors and is wide in the molar regions. So basically, the range of variation can be between 1 to 9 millimeter. It's a wide variation. We don't talk about the palatal, because palatal is all keratinized tissue. I love when I have to work on palatal. I have plenty of bone and plenty of keratinized tissue, and not much worriness about the tissue around the teeth. So for like everything else, for treating the recession, we also have to know what's the etiology. And I agree, sometimes we can't point the finger on a certain etiology and say that has caused the recession. Sometimes it might be multifactorial, sometimes it might be our best guesstimate, but we have to do our due diligence to find if there is an etiologic factor. So basically, if we know the etiology, we can treat the condition much better, because if you do the best surgery or best treatment, but you have not eliminated or have not recognized the etiology, it means it might not be successful. If you do the best graft, but the patient is doing a traumatic brushing and you don't get into the detail of their oral hygiene regimen, that is not going to work. So the etiology of the recession can be, patients have recession sometimes because they have a Perio disease. It's secondary to Perio disease. They lost attachment. And this is the worst type of the recession that happens in all surfaces. It's associated with inflammation. It's very hard to treat. Sometimes we don't even try. When the tooth is positioned buccally, there's more chance that you see buccal recession. If it's positioned lingually, more chance to see recession on that surface. So tooth position is important. Root prominence is important. The canines are the one, or the palatal root of the maxillary molars. The prominent roots, they're more likely to have recession because they have thinner bone covering them, and the gingiva and the bone, they travel together. You lose your gingival height because you have lost the bone support. So sometimes there is a recession because there is a bony dehiscence underneath. And when we open, we can actually confirm it, and it goes beyond. Sometimes I open a site and the whole root is looking at me. So the bony dehiscence recession might be giving you a message that there's no bone on that root. So be very careful in the planning. Again, going back to the positioning of the teeth, where a tooth is positioned out of their bony housing, and we see it more in anterior teeth rather than posteriors, and the root is only covered by the periodontal ligament and gingiva, and we wonder that even how that gingiva is holding up. So thin phenotype is another. If you see a patient with a thin phenotype, they are more prone to having the recession versus the thick phenotype. Minimal attached gingiva, abnormal frenum attachments, and shallow vestibular depths, they predispose the tooth to recession. Occlusion. Is occlusion a risk factor for recession? This is a controversial subject. So some claim that there is a direct association, and some believe that there's a secondary association. But there are two schools of thoughts, and there are literature on both sides. But bottom line is, when you notice there's occlusal issues, it's just prudent to have your patient assessed and address them. Some are, I'm very lucky I work with prosthodontists that they can do that. I can just refer and have it done by them, but some dentists, they do their own detailed occlusal analysis, and that helps addressing those issues. Sometimes habits could be the contributing factors. Some stuff like tongue rings, lip rings, oral hygiene, too much of it or little of it. Both can be risk factors. Pulling the dental floss into the tissue instead of wrapping it around the tooth and making that U shape can create these clefts that leads to recession. So we have to also ask about how they, when we see this pattern, then we get to the more detail of how they do their oral hygiene and they do the flossing that Dr. Barzilay mentioned. Most people don't like. So orthodontic movement is a huge factor. We see a lot of severe recessions on the mandibular anteriors. I'm sure you have seen these a lot in your practice when you send the patient for ortho treatment. But ortho treatment can also be an alternative treatment for recession. That's why it's always good to know what is the treatment plan, because sometimes if they push the tooth back to the bony housing, we actually can get some improvement for that recession site. Perio treatment, because we do osteoplasty and osteectomy, is one of the reasons that patient will get the shrinkage of the soft tissue, and we tell them about the recession that will be created. So we're not proud of it, but look at the before surgery and after surgery photos. You can see how much the retraction of the soft tissue has happened. It's inevitable. And I explain it to patient how it's gonna happen and why it happens. And that's how they gonna cope with it. It's a give and take. It's basically they get healthier gingiva, the periodontium, they get the treatment done, but then they have to deal with some, remaining sensitivity on the teeth. So if we expose the roots, we're causing dentinal hypersensitivity. In some patients are more sensitive to it, some they just learn how to live with it. So definitely that can cause, sometimes our restorative work, again, we all seen, as Tori mentioned, my background, my working as a general dentist for almost 10 years, gave me a good insight on what the general dentists they deal with, and trying to bring that when I see their patients to help the treatment. But we all have seen, and I had my share, that you place a restoration very close to the crestal bone, you start getting inflammation and the bone loss there. So it doesn't happen all the time, but it happens. Why does it happen? It all goes back to the concept that we all know, and is biological width. And we all say we think we invaded the biological width. What's a biological width? Biological width is nothing rather than a histologic description of that dentigingival complex that I showed you, that we assess. So the histologic description of it becomes biologic width. And it started from the study that Gargiulo did in 1961. He and his co-workers, they examined cadavers, and which was then the data, that's why the data is being referred to so often, because it's done in human and it's reliable. So they said we want to measure the amount of the attachment of the gingiva to the root, to the tooth. Part of it is the epithelial attachment, and part of it is the connective tissue attachment. So they measured the connective tissue attachment component and the epithelial attachment component. And they came up with a number, an average number of 2.4 millimeter. Basically, that was what they did. They didn't even call it biological width. It was a year later, Dr. Walter in University of Pennsylvania was the person who came up with the terminology of biological width. Gargiulo didn't even call it biological width. So then the term came and the concept came. Years later, it was 1984, so almost 20 years later, Nevins and Scoro, they said, okay, you know what? Let's also add the sulcus step to this complex, to this attachment, and call the whole thing biological width. And that's why you see the sulcus step is also there. During the study that Gargiulo did, the original study, that connective tissue attachment was the most consistent number in all the samples. The epithelial attachment was the one that was variable, very much variable. And the sulcus depth also was very variable. That tells us why sometimes we get away if we invade the biological width, because we might not have got very close to the crestal bone and the connective tissue attachment. So we need to know the concept, we need to respect it. But some people might say, some practitioner might say, but I've done it, I've done a restoration and I've done something. So it depends on, and I never had a problem. So it depends. Biological width can be different in people, can be different in one person, in posterior and anterior teeth, can be different in different surfaces of one specific tooth. So basically they came up, everybody likes a round number. Nobody want to go with detail. So they said, let's put 1, 1, 1, biological width is 3. But the reason sometimes we run into problem is that, I don't have the slide here, but that can vary from, I think something from 1 to 6, 7 millimeter. And that's why when I do the crown lengthening and I anesthetize the patient, or especially if it's aesthetic crown lengthening, I do the sounding. Patient is anesthetized, doesn't feel the pain. So I repeat my measurements. And now I want to see what is the biological width. I have got some idea through my consultation, but now I know exactly what it is. So it has considerable variation, which we have to be respectful of. So smoking, I don't look at the smoking, like the smoking, I didn't put it here because it's one of the risk factors. Smoking doesn't cause recession, but smoking is very important when we deal with the surgical treatment. Smokers, they have a compromised healing. We all know that, yes, nicotine can constrict the blood vessels in the gingiva. That's true, that's why they have less bleeding. But the problem we have is not because of the reduced amount of bleeding or blood supply. Because we have enough from periosteum, we have enough from the other sources. The issue is nicotine impairs the fibroblasts. And fibroblasts are the cells that they are responsible for the attachment of the gingiva to the tooth. So imagine, that's why we don't get good healing. Their healing lingers, and I usually bring them for post-op. If I bring a patient that is not a smoker in 1 week, I bring the smokers in 2 weeks. If I remove the non-resorbable membrane for other patient in 3 weeks, honestly, for smokers, I notice that I have to bring them back in 4 to 5 weeks. And that's when the soft tissue has moved and covered the top of the socket and the bone grafted site. So just keep in mind that that can affect your healing, but there's no contraindication for doing the treatment. So the take-home message is we need to consider and look into the etiology. Review your dental history, any history of ortho treatment, medical history, any habits, any perfunctional habits. Address all the aspects and interview the patient. Actually, it's a dental history is the time that I have fun. They're oral hygiene regimens, because sometimes they don't think you're going to get to something, and all of a sudden you find a very important piece of information. So now let's talk about the classification. Why? Because actually recession is one of the conditions that the classification tells us what would be the outcome of the surgery. So the classification predicts the outcome, how beautiful it is. Because if it tells you the outcome is awful, don't expect a good outcome. Why do surgery? So knowing the classification, and because one of the reasons that we may fail in our treatment plan is we might look back and say, I don't think I classified it properly. We all are familiar with the Miller classification, very straightforward. If your recession doesn't extend to mucogingival junction and there's no interproximal attachment loss, we get 100% root coverage, like this example. Class 2, the second condition stayed the same. Still, we don't have any interdental perio loss, but the recession has extended to or beyond the mucogingival junction. Again, if you put Miller class 2, if you have a Miller class 2, you're going to expect 100% root coverage. Miller class 3, the recession now not only has extended beyond to and beyond the mucogingival junction, but also we have the perio loss interproximally. We have the tooth that is not even in the correct position. The expectation, Miller said, expect partial root coverage. Miller class 4, the worst of the worst. Recession extends beyond mucogingival junction. There's a severe interproximal bone loss. There is a malpositioning. Don't even bother. Root coverage cannot be anticipated. That was Miller's classification. Then in 2017, all the perio brains in the world, they got together, they had a workshop, American Academy of Periodontology, and then they announced in 2018 the new classification that we are still getting used to it. Actually, in first day of my 3-day course, I have the most fun because at some section of it, we talk about this classification, pull it apart, that what are the changes? What's the rationale behind it? How to use it? Here, I just focus on what's related to the recession. I can't get to the whole thing. But if you notice here, basically, recession falls under the category of periodontal manifestation of systemic disease and developmental and acquired conditions. Very long name. Now we only have 4 categories in the perio diseases. So either health or disease. 4 categories. Third category with the long name, recession goes under mucogingival deformities and conditions. Let's say you don't even, you're seeing a patient, you don't even remember that name. Under that category, we have gingival recession, which might be buccal, lingual, interproximal. You have a loss of papilla, lack of keratinized gingiva. We have a abnormal color. There's a pigmentation on the gingiva. We have shallow vestibule. We have frenum pool. These are all your diagnoses. If you want to put a diagnosis there, just put buccal recession. You're dealing with the tooth. There's a recession on it. Buccal recession falls under mucogingival deformities and condition, and then falls under the other bigger category, the bigger name. So have a diagnosis there, even if it's as simple as buccal recession, lack of keratinized tissue. So in that, basically, Cairo came and introduced a new classification for the recession, which replaced the Miller classification. If you're not familiar with the Cairo's classification, if it takes time to get used to it, use Miller classification. It just, I'll tell you what's the difference, then you know that Miller is looking, the outcome in Miller classification is a little bit pessimistic. And the reason they changed it is they said, we have come up with a lot of great materials, great techniques. We get a lot of good results when we do the soft tissue grafting to have a root coverage. Even in the Miller class 4, put that in front of me, I will give you some root coverage with my techniques. And that's why they couldn't say the Miller class 4, no root coverage anticipated. We still can get some results. And said, Cairo said we have to update this based on the result we see in our patient. So the recession type 1 Cairo introduced is Miller class 1 and class 2. Is nothing new. He said, Miller class 1 was saying there's no interproximal. But if you are, sorry, I make it simpler. We said the recession classification is anticipating the outcome of the surgery. Miller class 1, we had 100% root coverage. Miller class 2, we had 100% root coverage. He said, if our focus is, what is the result? Why don't we combine these two categories? Doesn't matter where the recession is, what we're dealing with, we get 100% root coverage. So he put the class 1 and class 2 together, which at this point, we have no interproximal attachment loss. It's just the amount of the recession. Either it has got to the, here it doesn't say mucogingival junction, it's just a buccal gingival recession. It can be before mucogingival junction, at or beyond. He put them in one category because we get 100% root coverage. Then recession type 2 was actually the Miller class 3, which we have the recession extend to or beyond the mucogingival junction. But Miller said, no, we started having interdental perio loss. What Cairo did, he said, let's define that interproximal perio loss. We just can't say, well, it's this, we have a little bit interproximal. So he said, let's define it, let's make it a little bit more definitive. And here he said, okay, measure the interproximal attachment loss the same way you do in buccal, from the CJ to the depth of the sulcus. If it's less or equal to the buccal recession, you're looking at the root type 2 and look at the outcome. Something that Miller said is going to be a partial root coverage. He said, if your interproximal attachment loss is equal or less than your buccal or lingual, you get 100% root coverage. Why is that? Because we're relying on the bone and the papilla that is there for the blood supply and the bone to support it. So then recession type 3 became Miller class 4. Miller said, if you're dealing with this situation, forget it, root coverage cannot be anticipated. Cairo said, in recession type 3, which is Miller class 4, yes, we have a severe situation. In this situation, is severe because our interproximal attachment loss now is more than the buccal and lingual. So in that case, still full root coverage is not achievable. It means we can get some root coverage. So that was the change he made based on the advancement in the techniques and the science behind it, and their clinical experience, and to simplify it as well. And on the other hand, make it a little bit more exact when we talk about the interproximal attachment loss. So the take-home message here is clinical elements need to be considered when we do a treatment, which based on the classification we reviewed are recession depth, gingival phenotype, interdental, clinical attachment loss. Now, why we do it and when we do it. I'm just gonna, let me see how much time we have. Okay, not bad. This is a very important question. It's, why are we doing it? Because sometimes patients, they come to us and they have some clinical presentations that is associated with these recessions. When we're doing it, again, we come back, we're gathering the information to see what are the factors we have to look at. Now we learned what are the parameters we have to measure, how to classify it. It's important because it anticipates the result of a surgery now, why and when. The clinical conditions that mostly associated with gingival recession, and you all know, one is aesthetics. Large percentage of patients, they come in with aesthetic concerns. It's been shown that a lot of surgeries, a lot of soft tissue graft done for the root coverage purposes has been based on the patient's concern for aesthetics. Then we have dentinal hypersensitivity. There are studies that shows patients, they have described that dentinal hypersensitivity can affect their lifestyle tremendously. And we all have seen those patients and they come back. You see just 1 or 2 millimeter recession, but they tell you it has affected their lives. In our mind, it sometimes is hard to believe, but it is. There are cases that actually the hypersensitivity is really affecting them. So other things is sometimes we have carious lesion and non-carious lesions like abfractions. Instead of doing the restorations, it's shallow. Patient has some issue with it, but we don't want to, remove more of a tooth structure. If we can cover it with the soft tissue graft, that would be more conservative, especially if the patient, you do a restoration with the composite resin and they keep coming back and say it's sensitive, insensitive, or they keep coming back and the restoration, the class 5 restoration has fallen off. If you want to consider those patients for soft tissue grafting, consider doing the consultation or sending them when the feeling is not there. Either is lost and you're frustrated and you just want to explore other options, or you haven't done restoration. We do the grafting even after restorations, but it's very hard, especially with the great job that you guys do. Sometimes I look with my loupes and I can't even recognize the margin between the restoration and the cementum and the dentin. So basically it's better to consider it before that, but it can be done anytime. One of the things that I see in patients' mouth, and I don't let it go, is chronic inflammation. If you see this presentation, you don't see other teeth, but actually other teeth, they have excellent oral hygiene, excellent, zero plaque, zero calculus, and all of a sudden there's a heavy plaque and calculus around these teeth. Why is that? Because patients can't practice their oral hygiene regimen here efficiently because it hurts and they pull back. When you ask them, they say, no, it's okay, I can brush very well. But when you point it out to them, you show in the mirror, they come back and say, yes, I noticed that I can't brush really well on those sites. So when I see that situation, I get concerned and I start talking about the soft tissue grafting with the patient. So now, what if we leave recession untreated? And it's the case of all the recessions we are monitoring in our practices. What are we afraid of? Let's look at, first of all, another $1 million question. How much of the attached gingiva and keratinized gingiva is enough? Well, based on this very classic study that is still to this date we refer to, a minimum of 2 millimeter keratinized gingiva and 1 millimeter attached gingiva is adequate to maintain gingival health. So it means if you have 2 millimeter keratinized tissue, which 1 millimeter of it is sulcus, and you're only left with 1 millimeter attached gingiva, you're okay. If the patient can actually maintain a gingival health. Another study, it says the lack of keratinized gingiva is okay if the inflammation is controlled. That scares us because sometimes they say, then am I aggressive offering the soft tissue grafting to these two patients because of minimal attached gingiva? Yes and no. That's why recommendation for the grafting goes beyond just one simple measurements of the keratinized tissue. Like everything else in dentistry, we have to look at the big picture. We shouldn't get too much focus on one recession and one tooth, or even recessions in this mouth. We have to put that mouth back to the whole picture, which is the whole patient, and then decide on it. And I tell you why. We also have seen that teeth with subgingival retention, which means the margin of any restorative you do, either veneer, full crown, or or just DO, amalgam, or composite resin, goes to the sulcus. So the teeth that they have narrow zone of attached gingiva, they tend to show higher gingival scores, means more inflammation. The higher the scores are, the more inflammation is in that site. Now, why we are looking at the big picture and why are we getting this information? Because we want to get a guidance on what to look at, are we safe, monitor or not. We know this is another literature that tells us, okay, that's correct that we know sites with recession, they're likely to progress. So if you have a site that doesn't have a recession and the site with a recession, you're watching it because you know that might progress, and they are shown in the literature that likely to progress. Sites with the thin marginal phenotype, they are more likely to progress, and the recession increases with age. Why does it increase with age? It's not because we age, the gingiva age and recedes. It's, think about it, of putting all these micro trauma on your gingiva. You're doing an excellent oral hygiene. Have you been able to, and that was a very nice discussion I enjoyed having with Dr. Birek, and said, actually it's, and he believed, he said, this is the accumulation of those micro trauma that makes the recession increases with age. Otherwise, or sometimes there is another reason, because we have a wear and tear, and because the teeth gets, we have that eruption of the teeth for the compensation, and the whole mucogingival complex moves. But beyond that, that can also be another aspect of getting it. Now, there is a lot of studies. And usually in my usual presentation, I bring 3 or 4. I chose a very interesting one. Here, it's a study done by Kennedy and the co-workers. They came and chose some patients with the recessions, basically try to keep all the factors almost the same. But the beauty of this study was that it was done on the same patient. They came and they treated half of the mouth, the recession half of the mouth, with the gingival augmentation, and the other half they left untreated. So it's one person, it's the same oral hygiene, it's the same habits. Let's see what happens. They put these patients on the excellent oral hygiene and 3 months periodontal maintenance. Every 3 months periodontal maintenance means they saw these patients every 3 months and monitored their oral hygiene at home, and they did the periodontal maintenance for 6 years. After 6 years, they measured the parameters. They realized there's actually very little difference in the periodontal status of the treated sites, non-treated or treated, doesn't matter. Treated sites versus non-treated sites. So they realized in the presence of a good oral hygiene and compliant patient coming to the practice, you have the advantage of monitoring them to cleaning the teeth and professional cleaning being done. The recession actually can stay stable. The very interesting piece of the information came from the patients who dropped out of the study after a year or 2 years. When they wanted to reevaluate the patients, they contacted them as well. They got a hold of them. They said, we dropped out of the study. They said, we know, but come in for the reassessment. And they found on those patients that they had not had any periodontal maintenance for the past 4 or 5 years. They did not maintain a good oral hygiene. The sites with the gingival augmentation actually held up very well, but the site that they did not do the treatment has lost further attachment. So that tells us something. That tells us why we're comfortable monitoring some of these recessions in our practice. And we do a lot of monitoring. We don't jump into doing the treatment for a lot of them. The patients are compliant. They show up on their appointment. They follow the instruction. They have a good oral hygiene. And yes, that's why we don't see much progression. The patients who actually are non-compliant, we see those inflammation, are the ones we have, and they have a thin phenotype as well. Imagine what the combination. That's the ones that we have to be more hands-on. So basically, I mentioned some of the clinical conditions that are associated with recession. If a patient has aesthetic concern, we go ahead, do it. There's a hypersensitivity is an option. For carious and non-carious is an option. For chronic inflammation, for me, I just jump into discussing it with them. But there are also indications for treating recessions. We mentioned aesthetics, like this one. The guy kept coming back, monitoring. One day he said, I want to get it done. My friend, they make fun of me when I smile. We got it done. Root sensitivity. This one had maybe 2 millimeter, 1 millimeter or 2 millimeter recession. But the hypersensitivity was actually excruciating. He had a very serious job. He was in military and wanted to just get rid of it. It has affected the life. With the soft tissue grafting, root coverage, completely fine. So sometimes when you do it at the right time, it's a service to the patient. When we have a persistent inflammation, like this one, I would jump into discussing the option. If the patient declines, that's another story how we handle it. But in my professional opinion, you need a grafting here. Evidence of recession progression, that I'm relying on not much on the patient. Sometimes patients, they give an opinion that, oh, I don't think my recession has got worse, but my dentist said to see you. So I rely on the dentist report because I see a snapshot of the patient. I don't get to see the history. I try to get the history, but sometimes it's not very possible. So again, because we can't watch, we never seen them progress, we have to just put accumulated data and draw our conclusion. If they are at the increased root caries risk, by covering those lesions, removing the caries, or sometimes when they are like this, you have to go dig in. You feel like it's not actually a caries, it's not soft, but it's the area for the plaque retention, and it will get to the level that you're gonna see caries lesions. So it's prone to caries. It's still not the carious lesion, is one of the options of tissue grafting. If they have a thin phenotype, if they have they don't have enough attached gingiva and keratinized tissue. If pre-restorative, this patient was good on its own, but when he decided to go for veneers for all the anterior mandibular teeth, we did a soft tissue, we did the FGG. If you see, the red part is the FGG that actually has been successful, but is maturing. This is going to turn to that pink patch that you see at the apical part of the teeth. So to improve the soft tissue deficiency, sometimes we use the soft tissue grafting to improve those arches that they are deficient here, to improve that bridge appearance. Sometimes we do it pre-orthodontic or post-orthodontic. We prefer to see the patient pre-ortho treatment, communicate with the orthodontist their treatment plan, see if the teeth that we already have concern, are they going to be pushed out of the bony housing, inside, what direction, and then do our risk assessment and recommendations. Do we always do the treatment before ortho? No, it can happen before, during, after. But the perio monitoring of a patient going through the ortho treatment is very important. Unfortunately, we usually get them after the recession has happened and is severe. So here, I'm sure you all have seen these recessions. Hypharenome attachment, which is associated with the gingival recession. At the minimum, a pharenectomy. If we do the free gingival graft, the pharenectomy is going to be eliminated anyway. The other indication might be when we have forcation involvements. If here, forcations are very difficult sites to maintain. Most of the, even when they do the professional cleaning, most of the width of the tip of the curettes is larger than the fornix, the entrance of the forcation. So how do we expect this get better? This doesn't get better, it just gets worse. It's a matter of time. When? We don't know. So if I see that the soft tissue grafting can help the coverage of this forcation, I recommend it. So the take-home message is look for a dangerous triad. That triad is the patients that you have that they don't show up for their periodontal maintenance as you prescribed, they don't maintain excellent oral hygiene, and they have a thin phenotype. That becomes the patients that you want to do things sooner rather than later. Despite the fact that for perio surgery, we want the patients to have to exhibit an excellent oral hygiene before we can offer the perio surgery. For soft tissue grafting, we don't have to, because actually it helps them. Remember that the study, that the patients that they didn't have a good oral hygiene, left the study, no periodontal maintenance, the site with the gingival augmentation held up better than. Well, I'm not saying with the very poor, again, look at the big picture, which medical history is one of the big pictures. So factors that adversely can affect expected outcomes for a root coverage can be from 3 different categories. It might be patient-related factors. Are they smokers? What systemic condition they have? We have to get a very detailed medical history. How's their oral hygiene? How's their compliance? Can they even do that? Are they able to perform a good oral hygiene or remember to have the compliance? Or the patient that they have unrealistic expectations. Sometimes we can't satisfy every expectation. Some becomes defect-related factors. Did I classify the recession type correctly? Did I evaluate it correctly? And I like the very old classification, which was looking at how narrow the recession is, how wide it is, how deep it is, how shallow it is, because all matters is your blood supply. You're cutting a piece of tissue, you put it somewhere, and now if that somewhere is on a nude root, how do you expect that graft survive? You want a blood supply that eventually forms between the graft and the recipient site. Until then, where does it get the blood supply? From all the tissue around it. And that's why in the surgery part that I go through details in the course, we explain how to prepare to keep that in mind. But it's one of the very It's my favorite. The soft tissue grafting, if they ask me what's the most favorite procedure in Perio, is soft tissue grafting, because you feel you create things. And it's just fun to watch them over years, gets better and better. So what was the vestibular depth? Sometimes I dealt with shallow vestibules. I did connective tissue grafting. I even pulled up the gingival margin further. Looking back, I wish I had done it in 2-stage, because that's very important. If you have a shallow vestibule and you pull it up further, that's going to always create a problem. So later on, I can go and do another, like a frenectomy type, and then let that area be epithelialized. Or I could have done it from the beginning to a stage, but these are the patients that sometimes they don't want to go. And there's no wrong or right. It's all clinical preference, what works in your hand better, what is your experience as well. Subgingival restorations and caries or non-caries cervical lesions. Technique related plays a big part. Did you do everything correctly? You stabilize your graft and flap, you position the gingival margin correctly. Did you look for your graft has enough adequate vascular supply? Did you make a flap tension free, or the sutures fell apart because you just pulled the tissue up and you wanted to bring the gingival margin to the CJ? And did you use the appropriate technique? So that's why in the soft tissue consultation, what we're trying to do is we are trying to plan it. If we fail to plan, we're planning to fail. So we start from going through every single thing. What's the area that the patient has been referred for? What's the reason for referral? I want to know that. I want to see what the dentist's concern is. My concern might be added to it after my exam, but that's the main thing, main question that the dentist has asked me and expecting an answer for that. If I have other questions and answers, that's a bonus. What's the chief complaint of the patient? Any hypersensitivity, aesthetic concern, or pain? What's the medical history? A very detailed medical history. I cannot say to this date, I have patients that they tell me they have no medical condition or only one medication. When I dig in, it becomes a list of medications. So go dig through that, go through it very carefully. Dental history, I want to know oral hygiene, their periodontal maintenance, have they done any perio treatment in the past? Their social history, smoking habits, in a specific perfunctional habits, grinding, clenching. As I said, it might not directly affect, but it needs to be addressed if they're doing it. In the extraoral exam, I include one extra thing. We all do our systematic extraoral exam, palpable notes, blah, blah, blah. I add a smile line. It's important for me to decide on the type of the graft, if the smile line is low, medium, or high. Because is the graft going to show there? Then I put the FGG, it's going to be like a tire patch. Intraoral exam, don't forget to look at the palatal vault. If it's deep, flat, or intermediate, that tells you how far the palatine nerve and artery are located. So there's a purpose for every single question and assessment we do. Then we go to the tooth. What's the tooth number? What's the phenotype? We talked about that dentinogingival, pocket depth, BOP, recession, keratinized tissue, attached gingiva, mobility. Would you do a soft tissue grafting if your tooth is already mobile, mobility 3? That's the big picture. If we haven't assessed it, we can't make it. That's why sometimes when they give a radiograph, what would you do for that? It's hard to say. Tell me the parameters of the perio for that tooth. Then the classification. You're not comfortable with chiro classification and recession type, at least put the Miller type. You don't know at that point, you can't think off your head, take a picture. You have your probing, you have the picture, later on sit down, look at your probing and measurements, go back to the definitions, and then say, give the verdict, which classification you think it falls under. Do you have furcation concerns? Do you have concern about the vestibule depth? How's the surgical access? Sometimes we want to do a surgery. We have a difficult access. How am I going to plan for that? I always look at, I do a dental exam for the tooth or teeth that I'm doing their soft tissue grafting, because I want to do if they are sensitive to percussion, what's the vitality status? Do they have any root canal treatment on them? Is it successful? What's the bony pattern? If not, is there a possibility? And what's the restorative treatment plan? Sometimes there's none. Sometimes there's veneers, or that makes a difference in planning on a posterior versus anterior for the healing time. You don't want to do the soft tissue grafting. The restorative dentist puts 6 veneers, cement them, and the patient comes back and say, oops, the gingival margin has moved. That's a big oops. So have a PA, an appropriate PA from the site. Look for the bone level. Look for any finding that is not within normal limits. If you're dealing with the premolars, you want to also locate the mental foramens. We can't go and get a CT scan for every recession, soft tissue grafting or procedure we do unless we have a good justification for it. What's the endo treatment done? Patient may tell you nothing, but you take an X-ray and you see, oh, the root canal treatment is done. So we want that, because not everything looks the way you see them. It depends on the way you see them. And this is one of the cases that one of our very dear friends that is also a big pillar of our foundation and comes to Uganda every time with us, Dr. Ross, put this one once on the Facebook and ask, what do you think is that? Everybody started saying a necrotic piece of bone. Has this patient had radiotherapy, taking bisphosphonates, blah, blah, blah. Everybody, and he let everyone give their opinion for, I think it was 3-4 days, until he showed us the periapical radiograph. It was an impacted tooth. You wouldn't guess that unless with a lot of calculus on it. So basically, you may be surprised. You don't want to be surprised when you plan for your surgery. Again, look at possible etiology. There is no point if we do the best surgery and we have not been able to even recognize the patient doing the, have a tongue ring. That's going to happen again. They may have removed it temporarily. So then discuss everything with your patient. Procedure. How hard is after? What are the post-op expectations they have? Some people, I assess the patient, and sometimes I prescribe antibiotics if I feel like, because if the graft gets infected, means it's failed. But I also go case by case, based on their health history, based on how the surgery went, the site, again, the whole thing. I tell them that there's a possibility we don't obtain 100% root coverage, never promise 100%. If you promise 100% and you get 99%, patient is not happy. But if you don't promise and you get 100% or even 99%, everybody's happy. Discuss other grafting material, which this is again is part of the surgery course, because then we talk about autogenous versus allografts. We have to give those options to patients and go over the post-op expectation before the surgery. Sometimes you do that. The patient comes back and say, I didn't know you're going to put a pack, the co-pack on my teeth. There's a dressing on my teeth. I have to go and talk. I talk to my clients. I can't go like that. Somebody comes and say, well, I want to play. I'm a musician. I want to play, music. I can't do it. Get all that history and everything, their lifestyle, and they will tell you when you describe post-op. You don't even have to spy on them what they do. When I go through the post-op expectation with details, then comes out and say, oh, by the way, this is what I do for a living. How does it affect me? So very straightforward with how it can affect their lifestyle. Complication happens. I'm not gonna go through this, but I think it has been left from the surgery part, one of the slides. Complications may happen. That's why we advise our patients about. We warn them, we explain to them, and we explain what we're gonna do if it happens. And we just have to be there. If we can handle it, if we've done a procedure, we better know how to handle the complication arise from it. If we don't, again, help them with sending them to someone that they do know how to do it. So anyway, thank you so much for your attention. I try to go a little bit faster that at least we can get to a couple of questions and comments.
Thank you very, very much. You guys, there are a couple of questions and it's good that you left a few minutes and then some comment. One comes from Greta on me, and she said, thank you for the great presentation. I am a big fan of yours. You have been a great inspiration. The root coverage on class 5 existing restored cases, how do you make sure composite is completely removed before grafting? Do you use any special lights to identify the composite remnants?
Very great question. Thank you for your kind comment. But that's what I was referring to. It's very hard. I use my loops and the light on my loops. I don't use any special light, but it gets to the point that, again, that experience working as a general dentist, being in your shoes, I can recognize. For me, it's much easier, but I've seen the struggles. There's no specific tool. I go back with the Explorer. I try to see how it feels. I look at it. As I said, maybe the tactile is better. And I know most of the area, if I have removed it, then I have enough dentin exposed to do the attachment. But I think it's something to be done. If it's done prior to restoration, it's great. If not, it's not end of the world. Still, you want to look at that, your patient want it, or your restoration fails, we have the ways to deal with it.
Okay, there's another one from Dr. Gum. I guess it's just picking your brain here. He says, notwithstanding the value of the connective tissue graft, there is a lot of interest in the pinpoint surgical procedures. What are your thoughts on this procedure that eliminates palatal graft?
First of all, Dr. Gum, I'm a big fan. Thank you it's an honor to have you here and listen to me. So are you referring to the pinhole surgery or?
Yes, pinhole surgery, yes.
At pinpoint, I was confused. I don't do pinhole surgery. I'm not trained. I read and I read a lot about something before I get into it. It didn't get my interest, and I see patients coming back after the pinhole surgery to the traditional way, which using their own tissue and the autogenous. I think that's why I'm not the best. I'm not a good person to ask about pinhole surgery because I'm not doing it. That's why I can't give that information. But from my observation, things needs to kind of be attractive enough for me for the outcome to put that time and effort into it. And I haven't in this. I don't know what would be my decision later. But if the patient doesn't want their palatal tissue being used, I use alloderm. And that one I went to Dallas for the training with Dr. Pat Allen, who is the expert in the tunneling technique and use of alloderm. I did that before I go and see him, but then I realized what makes his work successful is the case selection, because I'm doing the techniques, the same thing, I'm following everything. I get good results, but I don't get the excellent results that he gets. So I signed up for the course, went to Dallas, and then I realized, yes, there are, criteria with the case selection that can make a difference. And then all goes back to the blood supply. So that's the way I deal with the patients that they don't want the grafting from their palate. I don't do the pinhole surgery. Sorry.
Well, we love your honesty and transparency. That's a Bahrami trait, that's for sure. He added a little more here. Dr. Kam said, an excellent step-by-step presentation. Your surgically hands-on will be a complete success. Thank you, Larry. We'll make sure that it is. Another comment came in from Akshay. And he says, I am a dental technician in Vancouver, but also an international dentist doing my license exam. This session helps me review my Perio for the exam. Thanks a lot, Dr. Bahrami. So this is very good.
All the best with your licensing. And
yeah, like the beauty is, I will tell you the type of person that Dr. Bahrami is. We did a course. I'm gonna let you go soon. We did a course, and of course, it was a sold out course, and one of the dentists, her car was stolen from the parking lot at the hotel. And she was really cool, but she missed about 5 hours of the presentation. And she said, okay, well, I missed it. But then Dr. Bahrami goes, no, you didn't miss it, because we're gonna make a meeting and I will come on Zoom with you for 5 hours and I will explain to you what you missed. This is the kind of dentist we bring, and that's, I love, like the people that we work with, and Dr. Bahrami is one of them. Now, keep in mind that at Spectrum Day Toronto, and I hope you guys come, Izchak, Dr. Barzilay is bringing his PACE, most of his specialists, for the potpourri, and we have Dr. Barzilay, Dr. Azar Pajou, Dr. Elahe Berouz, Dr. Abu Raja, and Dr. David Schwarzhead, Dr. Bahrami, of course, and they're dealing with complications. Because everybody looks great. Everybody looks to show their work when they're perfect, but sometimes it's not perfect. So I'm going to dismiss you. Thank you for a wonderful presentation, Parvaneh. You're the best. Okay, we love you, and we look forward to. I want to find out more and inform them on the comprehensive Perio course that you're thinking of doing on crown lengthening with the prosthodontist, with Elahe Berouz. With the option of live surgery, that's planned for 2023. Stay tuned. We'll keep you informed. Okay. So
we're gonna have, as you mentioned, it's the last courses we did. We had a lot of interest in having a live surgery. It's very planned, but we decided to just swallow all those efforts and work hard for you guys because I know it really puts it into perspective. And as Ettore mentioned, he's gonna kindly work even harder to make
we're gonna plan it together, because I know it's a lot of planning. These things are really a lot of planning in order to execute. I always tell I have some friends, Parvaneh, and they always say, well, I give you the idea. Ideas are cheap. It's the implementation of the idea that makes it successful or not. Implementation means hard work. But then in the end, it's the character of first, they have to be gifted individuals, okay? And I'm lucky enough that I'm surrounded by so many gifted people, they're willing to share. And so it's a gift, but it's also the character of the dentist or the presenter that is willing to share, their knowledge, holding nothing back. And this is, and they remain as mentors. Now I see, I see people, marketing their courses, and everybody's putting mentorship is the buzzword. Well, we started doing mentorship a long time with GUM 18 years ago. We've been together with Larry for 18 years, and then you coming in, mentorship. So it's good that everybody else is sharing on our success. I think it's fantastic. Okay. So, thank you for an informative presentation. We'll bring you back. There's another one. Wait, Dr. Bobby Beg. Yeah, thank you, Dr. Bahrami. Great presentation. This really connects with my crown and bridge presentation with Perio assessment for crown and bridge prosthodontics. Thank you, Dr. Bobby Beg. Okay.
We can do something about it.
Yeah, he's a nice guy. We can bring him into our family. Actually, he's already part of the family with the Crown and Bridge course.
Oh, Bobby, I know him very well. So
Yeah.
if
So,
it's a good match for the course, maybe we can talk further about it.
yeah.
But thank you, Bobby, for being here. I'm flattered. I'm humbled. Let's say I'm humbled by all of you guys.
We, you know, I tell you something, Dr. Bahrami, I am so happy with my TIA Academy because it's not really my TIA Academy. It's their TIA. It's the member academies, you know, and they contribute, they complain when it's the right time to complain. You know, they ask when they ask. And really what we do is we act on what they want to hear. And so, like I said, you know, like, I mean, we're planning already for next year, and it's going to be, again, bigger and better. We're going to do it. Okay, so you can go if you like, because I know you have another presentation. We'll talk to you soon. I'll send you a kiss. Bye-bye. Okay.
Thank you, everyone, for
Yeah.
your attention.
And then, guys, a reminder to you guys, okay, we meet again. Well, hopefully we meet again on October 28th at Spectrum Day Toronto. I remind you guys, it's all free. Bring your hygienist, bring your dental assistants, okay? We have 4 tracks and 62 speakers. It's unbelievable, and we'll have a party at the end. Then we meet again on November the 4th. November the 4th, we meet again at TIA with world-renowned Leslie David, okay? Implant-minded dental extractions, okay? Which is a component of the course with Dr. Gum now. She does a component on implant-minded extractions. And then we have Milan Jovanovic from Stroman Neodent. Why intraoral scanner is the gateway to practice the growth, to practice growth. And we finish this sheer program on November 18. And again, we're going to travel. We're going to travel to Italy. One of their best dentists is going to present, Dr. Silvio Mario Meloni. He's going to be talking about horizontal and vertical guide bone generation, okay, soft tissue management around implants. And we finish with Dr. Sam Omar, and he travels the world, is usually in the Middle East. He's going to be talking about macro versus micro planning, bigger benefits and smaller risks. And I think he's also going to touch on the partial extraction therapy. So I'm going to leave it at that. I thank you very, very much to all of you, you know, like the people that participated. Thank you to all the people that asked the question. You make it more real, okay? And I look forward to seeing you guys. Please, I'm walking around and running around at Spectrum Day Toronto, but please say hello. You know, some people I know very well, like the Awadala family. I hope to see you guys there. I'm glad to see you guys here today, Dr. Neil Silver, and all you guys, okay? So introduce yourself if you had never met, and we'll see you then, and bye for now. Have a great weekend. The weather's supposed to be good. God bless you all. Thank you very much.